The first view that we will discuss in the Pearls views is the parasternal. And really you can go in any order in this exam. You don't have to start with the parasternal, but for the sake of the acronym, we'll start here. So this gentleman is pointing out where the heart lies in the chest, and this will help us to know where to place our probe in the various cardiac views that we'll obtain. So in the parasternal view, you want to place the probe in between the ribs. About the third or fourth intercostal space is a good place to start trying to see the heart here. And you're going to be just lateral to the sternum. And you may need to hug up fairly close to the sternum to be able to see without lung getting in the way. And you'll want to make sure that the probe marker is pointed towards the patient's right shoulder in this view. And as you can see in this picture, another thing you can do to help you get a better view of the heart is to roll the patient onto their left side. And this causes the heart to flop over up against the chest wall so that it's closer to your probe and easier to see. And Dr. Botten has kindly allowed me to borrow some clips from a webinar that she put on with Dr. Mike Wagner. And so she'll be explaining some of the findings that you'll see in this view of the heart.
This slide shows the rule of thumb that in a normal heart, the right ventricle, aortic root, and left atrium usually take up equal thirds of the base of the heart. In the next slide, we focus more on the base of the heart. Looking there can identify left atrial enlargement by visually comparing the left atrium to the aortic root. Usually these are about the same size, and an atrium that is larger than the aortic root is usually enlarged. This often indicates ventricular dysfunction, especially diastolic dysfunction, and is also present in valvular heart disease and congenital heart disease. We see that we can also evaluate the aortic root for enlargement or dissection. An aortic root that's larger than about 4 centimeters is abnormal and can indicate dissection or a risk for dissection. That the right ventricle is also visible from this parasternal long axis view. If it is larger than the left ventricle, that can indicate pulmonary hypertension or right ventricular failure.
And here we see a comparison of 3 hearts. The one on the top left is what we would refer to as hyperdynamic, or in other words, its walls are closing in too much. They're almost kissing as they during systole. On the top right, we can see kind of the opposite occurring. The walls are hardly moving at all, and so there isn't much change between the systolic and the diastolic volume of that left atrium. And then in the middle of your screen towards the bottom, you can see a normal heart that has about 55 to 65% ejection fraction. And so looking at the thickness of those walls, as well as how much they move and how much the volume of that chamber changes from systole to diastole, can give you a sense of how well the heart muscle is functioning. And if you were to turn on your Doppler, you would be able to see the direction of blood flow as well. So here we see a jet of blue during systole that jets from the left ventricle into the left atrium. And so this is mitral regurgitation. It's the mitral valve here between the left ventricle and the left atrium. And it's a jet of regurgitation. So if you were to put your stethoscope on this person's chest, you may hear that they have a murmur. And now, if you have an ultrasound in your pocket, you can take a look and see where exactly is that murmur coming from. You can confirm to yourself, yes, this murmur is from the mitral valve. You can also see here that the left atrium is much larger than the aortic root in this case. So that mitral regurgitation is enlarging the left atrium. So there's a lot that you can quickly pick up on just by having a quick look through the parasternal long axis. And you can also, so you can see the mitral valve, which we've pointed out earlier, and you can also see the aortic valve in this view. And this aortic valve, you'll notice, has it's much thicker than a normal aortic valve. So in diastole, you can see some vegetations growing on that valve. So this is someone who has endocarditis. Now, looking for things that shouldn't be there, we can identify the left ventricle and the right ventricle. We can identify the left atrium and the descending aorta down towards the bottom of the screen. The AO towards the bottom of the screen marks the descending aorta. But then we have these other, so if you look on the image on the left, you can see that we have this extra black space where those two asterisks are. And then in the image on the right, you can see that there's a black space. Actually, there are two extra black spaces. One is marked by the two arrows, and the other one is marked by an asterisk. You can use the root of the descending aorta, which is marked with an AO at the bottom of the screen. You can use that to determine, is this fluid in the pericardial space or in the pleural space? So if the fluid is above that descending aorta in this image, then you know that it's in the pericardial space, and what you have is a pericardial effusion. And if that extra fluid is below the plane of where the descending aorta is found, then it's in the pleural space, and so you'd have a pleural effusion. So in the image on the right, we have both a pleural effusion marked by the asterisk and a pericardial effusion marked by the two arrows. So in the same location, this parasternal location of your probe, you can rotate that probe from pointing to the right shoulder over to pointing to the left shoulder. And with the probe marker pointing towards the left shoulder, you get the parasternal short axis view. And in this view, you can see you're basically so this is a normally moving heart on the left, and if you were to put a finger or a dot right in the center of that left ventricle, you'd see that all the walls move relatively equally inward towards the center. Whereas in the left, the image on the right, you can see that the heart it's not a nice circle anymore, and it's really not moving well. It's not contracting as fully as the one on the left. And so we can see that there's some dysfunction here. This particular heart, the ejection fraction is estimated to be 40%, as compared to the normal 50 to 55% that we see on the left. And one of the reasons this is very useful is in ischemic heart disease. So when you look at the areas perfused by certain coronary arteries, those areas tend to be fairly consistent, and so we can look at this donut shape and ask ourselves, okay, where are we on the donut? And we can locate where we are on the donut using the papillary muscles, which are being pointed out now. So you can see where those papillary muscles are, and then you can orient where am I in the donut, and then if you see some wall motion abnormality or deficit in a certain part of that wall, then you can begin to suspect that you have some ischemia coming from the coronary artery that feeds that particular part of the wall.